Okay, and for you guys are troops. You're hanging in here until the very end with us. So for our last session, I'd like to introduce to the stage Dr. Vincent Reynolds. Our session is on advancing technologies in cancer risk assessment. So Dr. Reynolds is a toxicologist. He has over 3 decades of experience in the chemical and pharmaceutical industry. Vinny's a very educated man, so I'm going to skip all this individual bio and to tell you, but something that's really interesting about Vinny is he's also a volunteer firefighter. So in addition to, being a toxicologist and a scientist, he's also a volunteer firefighter. So please join me in welcoming to the stage our very own Dr. Reynolds.
Thank you, Alberto, for that brief introduction, and also for the opportunity to participate in the session today. Before I left Indiana to come here, the weather warmed up, and then the wind started to blow, and I got hammered with allergies. So I'll do my best. The session today is entitled Advancing Technologies in Cancer Risk Assessment. And I'm so thankful to some of the previous speakers because they introduced some of the themes that I would like to build on collectively with your help. Particularly the theme of building bridges, which was immediately before lunch. Bridges between the scientific community and the fire service. This is something that is sorely needed. At the same time in this session, I would like us to expand our focus. In fact, I would say almost all of the effort at ameliorating the cancer concerns in the fire service to date have been spent on what I would call exposure minimization. And that is important. The culture change that has been realized with that is greater than really what you might think. I've been in the fire service since 1973, and I look back to what it was then versus what it is now, and there's been a significant cultural change. But I want to expand our focus beyond just exposure minimization, and we'll talk a little bit about that. I also want to point out that collectively, there's far more wisdom on that side of the podium than there is on this side, of course, excluding Alberto. And so your participation and contributions to the discussion today will make or break the success of this session. I really am calling on you to speak up and ask questions. On the first slide, do I have that?
Yeah, you should be able to. It's the black line on there. Sorry, it was hiding. Okay. So just green to go forward.
Green to go. And what's backwards? Red?
And red is backwards.
Some of the topics that I'll be talking about today may be completely foreign to some of you or completely alien and new. And so my email here is on the cover slide, and I'll leave it up there for a moment so that if you want to follow up with me afterwards, you can contact me, and I'll do my best to help you. Or you can contact Alberto. He has my contact information as well. So, having said that, let's see what we can cover today. As Alberto said, I am a toxicologist, and I want to provide for you the framework which sort of outlines the way I think about problems and how I approach problems. And I think this is relevant for us today because carcinogenesis is, at its core, a toxicology problem. And so this is the way I would approach it. The framework that I'm going to go through here very briefly was promulgated by the National Research Council back in 1983. And you can Google this up, or you can contact me, and I can send you the link. It's a document that's about maybe that thick, and I'm holding up my fingers about a ½ inch apart. And you can read through it if you'd like, and I encourage you to. But when you're done, this is what it's going to say. The 4-step process begins with hazard identification, which addresses a very simple question. Can the chemical cause a specific adverse effect? The answer to that question is either yes or no. Okay? It's a yes or no, up or down question. The next step is exposure assessment. How much of the test chemical gets on us? How much of it gets in us? That's a quantitative measure. The third step is, what's the relationship between the amount that gets on us or in us and the response that it might cause? So where are we on the dose-response curve? And most of you, I suspect almost all of you, are not toxicologists. I'll show you a dose-response curve here in a moment. You'll see what I'm talking about. But then from there we move to risk characterization. Risk characterization addresses the nature, the magnitude, the probabilities, the data gaps, and the uncertainties in understanding the risks for humans. And really it's a probability assessment, and it is accompanied by uncertainty. So for those of you who like to have everything locked up and tidied up and you know, all the questions answered, toxicology is probably not your gig. It's something that we have to deal with uncertainty, and we have to buffer ourselves against that uncertainty. The steps that I've outlined here in red, the red figures on the slide there, are really in the scientific arena. So that's what the scientists do. The last step, which is not in the NRC document, the risk management, that's what the shot callers do. The people out in the departments are the ones responsible for that. We advise, you know, here's the problems, this is what may happen. The safety chiefs, the wellness chiefs in the various departments then come up with the policies to address the concerns and answer the question what can or what should be done to control the human risks. I will tell you by way of caution that the most important step, or the most often overlooked step in toxicology risk assessment, is in the arrow across the bottom. Most, if not all, of the times where I've gotten into trouble as a toxicologist working for my company, it was because I failed in risk communication. So everybody, all the stakeholders, need to understand what's going on at every step. And I think back on my career, the times when I got jammed up on something, it's because of a communications breakdown. Either somebody didn't know what the message was that I was going to bring, or they weren't ready for it. And so it's very, very important to be sure that all of the stakeholders, and that includes family members. So if you're dealing with fire, you know, talking to the scientists here, if you're dealing with a fire service, you might want to loop the family members in as well. They have to understand what's going on so that there's no surprises. So where are we now? Here's the dose-response curve that I was talking about. In my view, looking at our progress to date, and I'm looking at it through a toxicologist's eyes, we have had a very, very strong focus on exposure minimization. So if we go back to, you know, the framework here, we've done a remarkable job focusing on exposure assessment and exposure minimization. We have had relatively less emphasis on looking at the response side of dose response. And let me just sort of ease through this slide here. And maybe I can use this to start to provoke some thoughts and provoke some discussion. When I say we have a strong focus on minimizing exposures, I call your attention to the green arrow there at the bottom. The x-axis here is the dose, or the exposure, and then the y-axis, or the vertical axis, is the response, whatever the toxic response is. If you start at the origin, and you move across the bottom, across the dose axis from left to right, so you're increasing the dose, nothing happens initially because our bodies can tolerate a certain amount of toxic insult, and we have compensatory mechanisms to deal with that. But eventually, as we move from left to right, we're going to begin to provoke some kind of an adverse response. And you can see the blue line start to climb, and it goes all the way up, and eventually we get a maximum response. We can continue to increase the dose, but we have maxed out the response. So if our response here is like, how many rats died, once 100% of the rats die, you can continue to increase the dose, but you're not going to increase the response. They're all dead. And so that's why these curves have this sigmoid shape. This is very, very typical. We have in the fire service over the last number of years really experienced significant cultural changes, and I don't think we should shortchange ourselves. I mean, we really should celebrate these cultural changes. When I started out, we didn't have the concept of decon, and I can remember a lot of the firemen that I worked with, this is like 50-some years ago, they look like that character Pigpen in the Peanuts cartoon, because we didn't know any better. But the cultural changes that we've brought about, with the SCBA policies, the personal decon, either on scene or back at the station, the idea that we have regular and routine laundering of the PPE, and other changes that are outlined in the Lavender Ribbon Report. Basically, if you collect all of what's been done and look at the green arrow there on the graph, what we've done is to try to minimize exposures and push ourselves from right back to left on the x-axis. And as we do that, we begin to back ourselves back down the dose-response curve. So wherever we were on that blue dose-response line, we've been backing ourselves down off the whatever point we were at, coming down closer to either the background level or the no response level. So that's the dose side. We have not put much emphasis on the response side of the dose-response profile. And so what I want to propose, or I want to address the question now, is where do we go from here? And I'm going to say a few words here about early detection of precancerous changes and how that might help us, and why it is important. And for those of you who were here last year, you saw this figure in multiple presentations last year, and it's such a darn good figure that it's back for an encore. Cancer, and we're talking now on response. Cancer responses typically require years to decades to evolve and emerge. They begin, if you look at this diagram all the way to the left, there are some normal white cells indicated by the little ovals there. Those are normal cells, they're healthy. The initial steps in the carcinogenic progression are commonly believed to be mutations to DNA. So we go from white to light blue with DNA damage, much of which is repaired with no adverse consequence to us, or no measurable adverse consequence. But some of them proceed on and result in mutations, which are the sort of the light pink ovals. So we've got some cells that have started down the path from normal to cancerous. Additional changes occur over time. If we think about it from a firefighting perspective, we go to some more fires, we get some more exposure to more adverse, more carcinogenic chemicals, and additional changes occur and they begin to accumulate. And that's indicated by the little different color symbols in the affected cells. And things continue on little by little with additional mutations, epigenetic changes, biochemical changes to the cells, and other changes which people haven't really even discovered yet, but I'm sure they're there. It's important to note that the vast majority of precancerous cells do not progress on to result in cancer. The vast majority of them do not. And we heard about this with the talk on clonal hematopoiesis, where there's a mutation. So that would be like one of these pink cells sort of over to the left side, and they just sit there. They don't progress on. Some of them do, but most of them don't. But some of the precancerous changes will progress on, and they give us an opportunity to determine whether the affected individual might be at increased risk for cancer. And as I said, the duration from going from a normal healthy cell to a frankly cancerous cell is years to decades. And we know this. I mean, I don't smoke a cigarette this morning and then go eat lunch and then come up here and clutch my chest and I've got a lump in my chest. I mean, I've got to really work at it over and over again, multiple exposures over a prolonged period of time, and eventually some people who smoke get cancer, most of them don't. Okay? So our body can defend itself, and there are mechanisms to push things back the other way. As a toxicologist, most of where I would work on this problem is sort of in the area indicated here on the left side. For individuals who are diagnosed with cancer, over on the right side, invasive or metastatic cancer, the problem gets passed to the clinical oncologist, and there are protocols for either surgical procedures or radiation therapy or chemotherapy to provide clinical benefits to the affected individual. The point I want to make today, and I really want you to study these next few changes to the slide, are that between the early step, the initiation and early progression of cancer, and the emergence of neoplastic disease, it's years to decades. On this slide, it's just, from one part of the slide to the other part of the slide. Doesn't look like it's very far. It's years to decades in our bodies. And there are multiple opportunities that this provides us with for early detection and early clinical intervention. And this is the response side of the dose-response issue that I think we need to expand our focus and begin to try to work into our efforts to ameliorate cancer in the fire service. This is going to require sort of new ways of thinking. It's going to require new bridges to be built, and additional research to determine what's the best way to do this. There are at least several methods that have been developed in recent years which may provide opportunities for early detection. And I show you here three of them. I'll expand on these in just a moment. The PIG-A assay is a mutation assay which I believe may fit early in this progression of events. Error-corrected duplex DNA sequencing, I think, fits somewhat after PIG-A, but has enormous value in terms of its sensitivity and its ability to provide mutational signatures, and we can talk about that. And then finally, once the cancer has formed, but before it has progressed to the point of lumps and bumps where we can feel it and we know we have a problem, ctDNA, or circulating tumor DNA, offers an opportunity for very, very early diagnosis of the problem before we would otherwise know we have it. Now, what is circulating tumor DNA? Cells in our body die all the time. And when they die, you can think of a cell as like a little grape almost. When they die, they break open and the contents of the cell are spilled out into the circulating blood. Okay? Among the contents that are spilled are the DNA, the chromosomes of the affected cell. And as that DNA circulates around before it's cleared from the body, the epigenetic markers on that DNA can provide an indication that the individual, in fact, does have cancer, although they may not know it yet. Okay, so there's an opportunity there for an early detection. As I said, I'm just going to say a few words here about these screens, and there are others. This is not an exclusive list. But the PIG-A is a gene mutation assay. It's rapid. It's very inexpensive. It is limited in the only tissues that you can use or that you can evaluate are blood cells. It will not identify the nature of the mutation. It will just tell you that you have a mutation. And it is sensitive to sample handling. So the individuals collecting the blood samples and transporting them and so on and so forth, storing the samples, they require at least some training so that the integrity of the samples is not affected. Where would it fit? As I said, it could go in early in the sequence for acute screening. You could do either longitudinal or cross-sectional studies. And I think its best fit is probably in terms of risk profiling. So you could ask the question whether among a group of people, some of them have a higher mutational burden than others. And those who have a higher mutational burden, maybe they get elevated in their annual physicals to a more stringent surveillance as opposed to the individuals who are, baseline in terms of their mutational burden. The error-corrected duplex DNA sequencing, we talked about this in the two previous symposia last year and the year before. This is a mutation assay. It is extraordinarily sensitive, exquisitely, exquisitely sensitive. It can provide mutational signatures, which is to say it will tell you the nature of the mutation as well as the flanking bases where the mutation occurred. And that signature can, in some cases, identify for you what the agent was that caused that mutation. Not every case, but some chemicals have mutational signatures. So if you had a hazmat incident and you were out, if Rescue 3 was out on the Cross Bronx Expressway for a tanker that was overturned in New York, and some of the guys got some kind of crud on them, and they're wondering, do they have a problem? What should we do? If there was a mutational signature associated with whatever was in the tanker, you could imagine applying duplex sequencing to determine whether they had an exposure, and that could help guide risk management after the fact. So that's one potential application. It also can be used on any tissue. So whereas the PIG-A is blood only, duplex sequencing, you can collect a biopsy of any tissue and do the analysis. One of the drawbacks of it may be its cost. I don't know what it costs, but it's going to be more expensive than duplex sequencing, than the PIG-A. Applications, as I said, you may be able to demonstrate linkage between the causal chemical and the adverse effect. And again, you can use that for risk profiling. It's fairly early in the carcinogenic progression. And then finally, ctDNA epigenetics. The FDA recently came out with a guidance on ctDNA methods and applications. And if you go to my LinkedIn page and you work back up a few months, I posted that guidance on my LinkedIn page and you can find it there. Or you can just email me and I'll send it to you. No big deal. The CT DNA epigenetics approach looks at epigenetic changes on circulating DNA that was shed from tumors and is circulating around in the body. This is a minimally invasive procedure. It's like a blood draw. It detects the presence of cancerous cells, and it does so in a way that can identify the tissue of origin. This is remarkable for its potential applications. It's something that I had relatively late on the diagram on the previous page because there has to be enough of a tumor mass present that the DNA that's being shed is enough above background that it can be discerned and detected. So stage 1 and stage 2 cancers, not so good. Stage 3 and stage 4 cancers, from what I've read, it's much more sensitive and much more effective at detecting those. Now stage 3 and stage 4 is sort of, you're getting out there on thin ice, but you can detect these the presence of the cancer before you otherwise might. So early detection of frank neoplastic disease is where it fits. It may be insensitive, as I said, to very early tumors, and I'm not sure if, I know if the gallery or the Grail people might be here, they can, during discussion, maybe they can offer some advice on this. I'm not sure if it can detect all tumor types, in particular for brain tumors. I don't know whether brain tumors would shed DNA across the blood-brain barrier into the peripheral circulation where it could be detected or not. So I just don't know, and I'd have to get their advice on that. And then again, cost. As these assays come online and more people use them, the cost per unit assay is going to drop, but right now they may be expensive. One of the problems that we face in science, I mean, I've been in industry my whole career. Industries, they compete against one another because they want to get their product to market. People in the academic community, they compete against one another because they want to be the first one to get the publication or the grant money. This is the nature of the business that we scientists work in. We don't make these rules, they're imposed on us. What I encourage us to do here, though, is to compete not against one another, but against the problem. Cancer is a very, very tough problem. We need to collaborate and work together to compete against it. There are different research communities, academia, government. We've heard some government research, from NIOSH. There are commercial, industrial companies that are studying this problem, and there are private groups that can fund some of the efforts. On the other side, there's all these various fire service groups that are crying out with different needs, all of which are valid. And we need to try to build a bridge between the two sides, the two groups that are represented on the left and the right-hand side of this slide. I'm going to suggest that one of the things we need to do for early screening is to develop an algorithm. We cannot realistically expect municipal fire departments or rural fire departments with the budgets they're operating with to simply say, we're going to screen everybody once a year at their annual physical. If a diagnostic screen of this type I had on the previous slide, let's just say it costs $1,000, and you have a department that has 1,000 or 1,200 members. I'll take Indianapolis. You have 1,200 members in your department. Okay, to run the screen on all your members is $1.2 million. Okay, you just can't incorporate a line item in your budget like that without some pain. And so there needs to be some kind of an algorithm where we decide what's the best time to incorporate these screens in the lifetime and in the life cycle of the individual, where on their career track would it give us the most clinical benefit, and are there ways to identify people who may not really need the assay? And that's why I say an algorithm. So there could be early screens to identify subsets in the workforce who have higher risk profiles and therefore warrant more stringent medical surveillance. They would progress on and get the more expensive tests. The rest of the individuals may not, or they may get it later in life or with greater intervals between the tests, and so on. So someone with a higher risk profile, instead of starting them on one of these diagnostic screens at, say, age 52, if they have an elevated risk profile, maybe they start at age 43. And instead of getting the test every 4 years, maybe they get it every 2 years. We need an algorithm because we have to be sensitive to the budgetary restraints, that we operate under. We have to be cognizant of that. And so an algorithm, I think, is going to be necessary if we really want to improve clinical outcomes. And that's what our goal here is. There's a couple other questions that I'll tee up, and then I'm going to stop talking, and you guys can start talking. Additional focus areas. This list is not exhaustive. This is what came to mind when I thought I could put something up that would be provocative and maybe get some discussion going. We need to expand and leverage the value of tissue banks. I know, Alberto, you have some tissue banks. Other healthcare providers throughout the country have tissue banks. And basically what these are, when someone is diagnosed with a cancer, this may sound a little morbid, but some of the cancerous tissue is removed and it's stored for future study. And these tissue banks can be gold mines where information can be obtained studying characteristics of tumors from different people. We need to leverage the value of those banks more aggressively. There are gaps, going back to the four-step risk assessment paradigm that I alluded to in one of my earlier slides. There are gaps in our hazard identification, and we touched about on these in some of the previous sessions at the symposium here. Smoke from new products like the lithium-ion batteries. This is a new beast. It may have hazards that we haven't imagined, and we need to understand what they are. Dermal absorption kinetics. I recently did a risk assessment for an individual, and I was surprised, I shouldn't have been, but I was, at the magnitude of dermal absorption. And thanks to Kenny Fent and Gavin Horn, it was their work that demonstrated this. But benzene is very readily absorbed across the skin. The PPE, Alex Mayer talked about this last year, I think it was, at the symposium. He's in Kenny Fent's group. The personal monitoring inside an individual's turnout jacket and outside the turnout jacket, benzene from outside to inside was knocked down only 10%. So the concentration inside the jacket was 90% of what it was outside. So the PPE does not protect against dermal exposure, even if you're wearing the SCBA. And was did dermal exposure occur? The answer is yes, because benzene metabolites were picked up either in the expired breath or in the urine. So that's an area we need a better understanding of. We talk about shower within the hour, it might be too late. Maybe we need to focus on more rigorous decon sooner. I just don't know because I don't know the kinetics. I don't know how fast this stuff gets across skin. We talk about concerns that confront our female firefighters, our sisters. I recall, and I can't remember where this was, but a number of years ago, a female firefighter had a baby. She went to her departmental leadership and asked, well, how long should she refrain from nursing her baby after she comes off shift? And they didn't know what to say. They had no data. I think the recommendation was to wait 48 hours. You know, what's the scientific basis for that? If you get PAHs in your system, they're probably going to deposit in adipose tissue. They're probably going to be fairly long-lived, and they may be present for days, if not weeks, after an exposure. Okay, so if a female firefighter comes and has that question, we need to come up with a more science-based response and give her better guidance. I just don't know what the elimination profile in mother's milk is for some of these agents. And if there's an uncertainty there, maybe the risk management decision is to take her off the rigs, you know, take her off the fire ground, and give her light duty or whatever the term your department uses until she weans her child. That's you know, maybe that's the best thing to do. I just don't know because I don't have data on the excretion profiles in mother's milk for these agents. So to me, that's a data gap. We need to look more aggressively, I know Alberto does this all the time, at funding for cooperative efforts. I was in industry, so I never had the Chase grant money. But funding is important, and we can only do what we can pay for. A question that I have for this group, for Alberto and anyone else, is there enough substrate here to support the formation of our own scientific society addressing cancer concerns in the fire service? And if that's an overreach, is there enough substrate to form a specialty group within an existing society so that the scientific community can gather, you know, individuals who are interested in working in this area, you know, into a smaller group with more focus and hopefully more aggressive pursuit of some of these objectives? And then there may be other questions that you may have, which I didn't put on my list, but doesn't mean they're not valid. And at this point, I'm going to stop talking. As I said, there's more brains on that side of the podium than there is on this side, and I'm really depending on you and asking you, if you have questions, ask the questions. If you have ideas, give voice to your ideas. If there's ways we can build bridges between the scientific community and the fire service, you know, let's do that. You have my email from the initial slide, and I'm going to stop talking. My voice is not going to last that much longer anyway, so I'm going to pause.
Right, if we can open up for the audience, and we can turn on the lights in the room as well, just to ask questions and discuss. I think this is an opportunity that Dr. Reynolds wants to be able to have a discussion around this risk assessment and the application of technologies. So questions and comments. And please come up because we have folks that are listening online so that they can hear you.
Dr. Reynolds, thank you for taking us on a field trip into the future. So mine is not necessarily a question, it's more of a comment, but while that's ideal, it's really tough to execute on the clinical side or in any other way. So I don't know if you were present yesterday for Dr. Taylor's discussion, where they do like in-house 60 gene panel, right? So even in a precancerous setting, let's say you analyze a panel that contains 60 to 100 to 200 genes, right? So first of all, you're consenting a patient to that. So there's an expectation that those results are then discussed.
Mm-hmm. Absolutely.
And so let's just say that you get the results back and you come back with a handful of somatic mutations.
I know where you're going.
And you're sitting with that patient, right? So first of all, you're going to take the time from scratch to educate germline versus somatic. Second of all, like in my husband's case, so he had a KRAS G13D, right? So everybody's super excited about it, but there is not a damn thing we can do about it as far as it being clinically actionable, right? So whenever you're sitting in front of that patient that's not well-versed in what this has to do with, they're essentially looking at you and saying, what did you say is wrong with my RAS? Mm-hmm. So somebody not only has to order that, then somehow go to bat for it being paid for by someone, but then also have that follow-up conversation as to the implications of that, so it's just really tough. But this is such an important conversation, and I think that there are enough commercial labs out there that have really good scientific technology mm-hmm. that have existed for a long time, who are willing to fall into some sort of carved out niche, which, you know, firefighters are, that I think you have really good chances for somebody to partner with you and actually foot that cost. It's just that I think the question is who's gonna own the conversation up front and in closure.
So very good points, and much of what you said alludes to the arrow that was across the bottom of the slide, the risk communication.
Mm-hmm. Nobody wants to do that.
I would not spring, you know, this approach on the Birmingham Fire Department, for example, mm-hmm. without meeting with the officers, the members, and possibly family members, saying, this is something we're going to be, you know, bring on a trial basis. This is what might happen, so that all the stakeholders know at every step what's coming. Even at that, there can be surprises. So that's one point. Risk communication, it has to be there. Sure. The second point I would make is that in terms of the consequences, if I were a member of Birmingham Fire Department, I would go to the captain there and I'd say, wait a minute, if I take this test and I come back with an elevated risk profile, are you taking me off the rigs? Mm-hmm. Okay?
That's the ethics.
Because I don't want that. Okay, now medically, the decision may be he really should come off the rigs. Emotionally, he doesn't want to do that. And that gets into the risk communication piece. And those are hard conversations to have, and they're hard conversations to anticipate. One other thing that I would really encourage anyone that wants to get involved in working with some of the vendors to validate some of these tests, please, 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 and Alberto, maybe you can take this as an action item, please come up with a common questionnaire so that results from one study in Nebraska can be compared to results from another study here in Florida. You want to be able to compare the two methods in terms of their efficacy. And please, please, please include BMI on your questionnaire, on the data collection, you know, the demographics and the personal information. Include BMI. Obesity and excessive fat contributes to elevated inflammatory activity in individuals. It's a known risk factor for cancer. Okay, you can decon all you want, but if you're carrying around an extra 40 pounds, you have elevated your cancer risks. And the BMI is an important potential confounder that needs to be factored into the data interpretation. And please, please, please consult statisticians when you put these studies together, so that you don't have tiny little pilot studies that are too small to draw meaningful conclusions. They're big enough, a study can be big enough to create all kinds of headaches and problems, but too small to really provide guidance for the solution. So make sure your studies are appropriately statistically powered. Please do that. And all of that gets back to risk communication and being sure everybody knows what's going on.
Well, and the second comment I wanted to make is that if you don't hear me say anything else, hear me say thank you. And if I could have this conversation on repeat for everybody that treats actually advanced cancer patients, because even though NCCN guidelines on every single page say that advanced cancer patients are best treated in a clinical trial, we still have only 1 in 4 patients that get this done. So thank you for that.
Next up is T. Guidati. For those of you in the fire service who don't know him, whether you realize it or not, you owe an enormous debt of gratitude to T. When it comes to representing firefighters in legal proceedings relating to health consequences, he has gone to bat for many of our brothers and many of our sisters. So thank you, T, and I'll take your question.
Thank you. That's very kind. Just want to say a couple of things. One thing is that there are many other reasons for consulting a biostatistician when you do these studies, and one of them is defense, because you know that there are going to be lots of studies that are underpowered that are going to be produced as a defense against allegations of risk. And one of the favorite techniques shall I say, not well-motivated interests on the other side, is to do underpowered studies that predictably will not give you a definitive result. That was one of the main reasons they were able to delay the tobacco and smoking issue for so long, and so forth. So statistical power is fundamental to validity of research. It's also fundamental to ensuring that the best work prevails, because a lot of shabby studies are going to be done in order to suggest that these chemicals have no effect. And if they do have no effect, which I don't think is true, it should be demonstrated with a study that has appropriate statistical power. But moving on from the toxicological terminology to epidemiological terminology, one of the issues is with the introduction of these advanced early testing methodologies is going to be positive predictive value. Mm-hmm. And whether or not some of these tests are overly sensitive for cancer, or whether they overly predict biological changes interpreted as cancer formation. I guess we just don't know yet how that's going to play out. But the whole issue of what they're actually predicting is a big one.
You can be caught between the two horns of sensitivity and specificity.
Exactly. And again, risk communication and having open discussions, mm-hmm. so everyone understands this is really critical. I think also that there are other reasons for looking at some of these things other than clinical diagnosis. Compensation is an issue, establishing causality when you have a claim. Fitness for duty going forward, whether an individual is safe to return to their assignment.
That's a big deal.
Yeah,
there's a lot of where I live. If a fireman is put on light duty, it's 24 on and 48 off where I live. If they're put on light duty, well, they won't report the injury in the first place,
right?
Because if they're put on light duty, and then they're seen during their 48 off at their side hustle, they lose their job. So if there's a bulldozer operator or an excavator or whatever on his 48 off, and he's supposed to be on light duty, and somebody drives by and they see him, he loses, so they won't report their injuries. That's an important consideration.
It is.
I mean, that's part of the firefighter's mentality.
Yeah. And then just the last thing is your call for some kind of a working group or forum for discussing this kind of thing, either as a part of a larger organization or a specialty society. We have a plethora of small specialty societies or special interest groups. So ideally, you'd have it as part of a larger group. I just can't think of a large group that would allow the focus or have the discipline to do this kind of thing. But I agree that that would be very valuable.
And Dr. Reynolds, we have a queue, so we should.
Okay.
Yeah.
And before the next question, going back to the statistical thing, Chief O'Neill and the other torch awardees, as you think about your research program that you're going to be undertaking over the next year, do give some thought to the data that you'll be gathering and what sort or whether it should be evaluated with some kind of a statistical eye. Maybe what you're going to do doesn't lend itself to that, but if you are collecting quantitative data and you want to do statistical analysis, work that into your study design up front, would be my advice. Yes, sir.
Yeah, so you had mentioned obesity and BMI quickly there. With our high levels of exposures, how much do you see exercise, like activating positive genes like PGC1 alpha and TNF, how much do those really truly offset our risk profile? And where does the fire service have room to improve upon, whether that's just reducing our total carcinogenic load or improving our resiliency through health and sleep and exercise?
Well, Alberto, throughout his professional career, has really focused on the total health approach to questions like that. I don't think, Alberto can correct me if I'm wrong, I don't think you're going to get yourself in trouble by exercising. I do know that you can get yourself in trouble with excessive body weight. And I'll just point something out here. I saw a paper. I'll dredge it up if anybody wants to see it. In their first year out of the academy, the average body weight gain for a new firefighter is 20 pounds. Okay? That contributes in some measurable way to their cancer risks. They're carrying 20 pounds of excess adiposity around with the elevated inflammatory activity that's associated with that extra body weight. You know, that might be a big deal. We could study that, I suppose, but 20 pounds in your first year on the job, that's a lot. Probably because they're stuck on the medic truck, or there's, you know, I don't know. I don't know how your department operates, but so did you want to respond any further to that?
No.
Yes.
Did you have someone in line already?
No, keep going.
Yep.
I want to discuss something about, you posed a question about breast milk kinetics, like how much the carcinogens stay there so that we can give informed decisions to pregnant firefighters. And then we discussed the statistical population size to make it actually valuable. And on top of that, when you consider the BMI of each firefighter and the PAHs get usually deposited in the adipose tissue and then can slowly released over time, you have a lot of variables and not enough population. Imagine female firefighters, 10% of the workforce, and then how many of them are pregnant, and then how many of them are going to get exposed into a fire situation, and then finding them, recruiting them, and doing experiments to collect their breast milks and analyze to get that kinetic is already a challenge in itself.
Very true.
And so what do you think, in your experience, a person can approach to this problem?
So there's a couple of things. In addition, if you want additional variables that affect kinetics, you can just look at the concomitant medications that the individual is taking, because some medications are CYP4A inducers or CYP4A inhibitors, and that can affect the metabolic activity in the liver for the various enzymes through which PAHs are biotransformed, and so there's a lengthy list of variables that can affect the results. So one thing that can be done is review the animal data.
Which doesn't translate very well.
It may not translate directly, but with appropriate use of safety factors, animal data are translated to human situations every single day. Okay? I mean, in my career, I've done it more times than I can count. You apply safety factors, and you come up with some kind of guidance that way. There was another thought I had. It went out of my head. But your point is well taken. The number of female firefighters that we have, they're not well studied. There's not that many of them, and so getting the statistical power behind a study design is going to be more challenging. I agree with you 100% on that. And the number that are pregnant is smaller still, and then the ones that are nursing, that's only a very narrow time frame of their lifespan or their career span. So that reduces the study population further, and so that would probably move me over to relying on animal studies. And now what came back into my head, for compounds to be registered under FIFRA, the Federal Insecticide, Fungicide, and Rodenticide Act, so for an ag chem to be registered, they have to do excretion studies in lactating mammals. So there may be some data which could be unearthed. Not all of those data are published, but there may be some information that could be unearthed and used as a guide. But at the end of the day, you're going to have to use safety factors to buffer yourself against that uncertainty. We talked about uncertainties, you know. You just highlighted an area of uncertainty. Yes, ma'am.
Hi, my name's Renee Pelletier. I'm a genetic counselor by training. So on the topic of uncertainty, I want to thank you for bringing that up, because I think a really great idea for the community moving forward in any of those discussions could be partnering with genetic counselors who are particularly trained in navigating that uncertainty when we're talking about any type of genetic disease that's being diagnosed, whether that's in the preclinical phase or once someone's diagnosed with cancer. So just a plug for genetic counselors. If you're meeting with an oncologist, your primary care provider, they're a really great resource to help you understand any results. Really, we're trained in helping folks understand genetic information.
That's a job I wouldn't have for all the tea in China, because when you guys are called upon, it's usually not a happy conversation.
Yeah, they can be really hard conversations.
Very, very hard.
Dealing with uncertainty is, a difficult topic to navigate. But that's why we're trained to do it. So you could fit very nicely in that risk communication piece. Exactly.
Yep. Okay. Yep.
But secondly, so I mentioned I'm a genetic counselor, but just for conflict of interest purposes, I am a medical science liaison with GRAIL. We have the first and only clinically validated multi-cancer early detection test right now on the market. So early detection is really a passion of mine. I think one thing that in being here the last couple of days, and I was in and out at our booth, but one piece of the conversation that was missing a little bit up until now was early detection and talking about cancer screens. So we at GRAIL have a Firefighter initiative now, and so I've learned a lot about adherence rates to some of the current cancer screens. They're pretty low within the firefighting community. And one of the issues that we talk a lot about is when we only have a few screens actually for cancer that are recommended currently by USPSTF. They're kind of the governing body for cancer screening. So when we think about a profession that's mostly male, that actually goes down because we're taking away those mammograms, we're taking away those cervical cancer screens. There's really only less than a handful of screens that we can offer right now. And this is
PSAs and colonoscopies.
Exactly. And PSA is now downgraded, if people don't know, to a grade C recommendation, which means this is really done on an individual basis. I think one thing that's been great within the firefighting community is they are still fighting for those types of screenings, knowing the elevated risks. But I think the big issue here is there are many, many different types of cancer, and we're only screening for a very small portion of them. We're missing a lot of cancers, and that's leading to those later stage diagnoses. So innovation and partnering, you mentioned like partnering with industry is really important moving forward because that's where a lot of that innovation and opportunity is. So I have a lot to say, but yeah, I think early detection is super important. And some of these multi-cancer early detection screens that are on the market are showing an ability to pick up some of these really aggressive cancers, stages 1, stages 2. Of course, with cell-free DNA, you're going to detect a later stage better than an early stage, but those...
Is it good for brain tumors?
No, so cell-free DNA doesn't cross the
blood-brain
No,
barrier?
it doesn't.
Okay.
I'm sure there will be innovations to capture that in the future, but right now, cell-free DNA doesn't do that.
I didn't think so.
And then just on the topic of cost, because I agree that is a barrier, and that's something that needs to be faced with a lot of innovation, thinking about how you can access grants to supplement some of your screening programs. I think we heard a lot about like mobile clinics and things like that can be really helpful in making screening accessible. But I do think just when you're thinking about your funding for your firehouse or your union, whatever you're advocating for, don't just be short-sighted in terms of the cost of the actual test, because we know that the cost of treating a late-stage cancer is a lot more than treating an early-stage cancer. So we really do need to think big picture of, what are you spending annually or, within a decade on treating cancer and the healthcare costs versus screening. And so that's just an important thing to keep in mind whenever you're faced with these opportunities for screening. The upfront cost might not be the only barrier, and there may be some screens that are going to lead to a lot of cost with false positives. So I really appreciated that comment about PPV, because that's a really important metric to stay aware of whenever you're evaluating new screening tools. But yeah, I fully agree. It's always going to be a balance between sensitivity and specificity, and that's something that you need to talk about with your groups and what's most important. But I think minimizing false positives, the anxiety that comes with those, the cost that comes with those, at Grail, where we feel that that's most important when we're thinking population-wide with screening. So that's what I had to say. Thank you.
And I'm speaking to a group that has a lot of firefighters. The early screening is like a smoke detector. Okay, would you rather go to a pot of meat on the stove, the smoke detector goes off, you get there, and you can handle it with a can, or would you rather wait until it's fire out the windows or fire through the roof because you didn't have a smoke detector? That's the analogy, okay?
But also, we want to be strategic, if I may, just to play devil's advocate. We don't want to be screening for all cancers and everything. Should not be a panacea of screening. We want to use our evidence strategically, and where our epidemiologic evidence suggests that firefighters are a higher risk for certain types of cancers, those are the types of cancers we want to be screening. So I don't want to necessarily advocate that we're conveying a message of screen everything.
This gets to the algorithm. We need an algorithm that tells us what to look for and when to look for it.
Yep.
And when to keep hands off.
Yeah, we'll do our last question and then we have to wrap up. So, Chief Rogers.
Lieutenant, but thank you for the promotion.
Oh, Lieutenant Rogers.
Admittedly, this whole conversation has been very sciencey. I've understood maybe half of it or less. But speaking from experience as a breast cancer survivor, at the age of 38, diagnosed with the rarest, most aggressive form of breast cancer, normally associated, triple negative, normally associated with a BRCA1, BRCA2 mutation. That was the first thing they tested me for. They sent me to a geneticist. I've had tons of genetic tests, all negative. My concern personally is I have a daughter. She's 23 now. She's 5 years within range of really needing to start aggressively being diagnosed, which was 10 years younger than my age of diagnosis. If I have some kind of genetic mutation, I want to know about it so I know what we can look for with her or if she's at risk. The problem has been the geneticist has always told me, well, as more come available that insurance will cover, again, we're going back to cost, you can get those done. Otherwise, you can go to California or out of state and pay thousands of dollars to have this done. The frustration on my part is knowing the science shows that I'm at an increase, or we are at increased risk for cancer, knowing I pay more for insurance every month than I pay for my vehicle. Insurance won't cover these things. Why can we not get insurance to cover more aggressive screenings for us? I think I know the answer is that cancer is a billion-dollar industry, and they'd rather pay for me or reap the money when after we get cancer than try to diagnose it early. But the problem is we're stuck in this. Unless cost-wise we are willing to pay even more out of pocket than we're already paying for insurance that doesn't cover much of anything. How do we determine what we're at risk for, and especially what our kids, because of the genetic mutations that we've endured through our job, if our kids are more at risk?
I don't dispute the financial challenges that a cancer diagnosis brings to an individual. I would say, however, the idea that someone would want to move you from one bin of care to another because they can make more money, I don't think that's accurate at all. I know for a fact, having worked on oncology drug development programs with a number of different indications, that tailored therapy in the cancer world now is really the approach. So it's not a matter of trying to expand and have your drug indicated for as many cancer patients as possible to maximize sales. That's not the case at all. It's a case of trying to find the individual characteristics of the individual patient's cancer and then find the best drug to fit that specific niche. So you referred to some of the markers on the breast cancer. Breast cancer is one of the most studied cancers, and so it has probably the best tailoring, perhaps. But other cancers are being approached in the same perspective, where not all prostate cancers are going to be the same, not all colon cancers are the same. The therapies are being tailored very specifically to very narrow bands of tumor cell types with different markers. And that's just, that's the way the field has evolved as the technology has advanced. And I'm very sorry for the financial stress that you've encountered. It's beyond the scope of my ability to respond in this session, but it doesn't mean that I'm not sorry.
So we're at time.
Very quick comment.
Okay, a quick comment.
Quick comment. We were discussing about circulating tumor DNA and how it cannot detect brain tumors because they don't pass through the blood-brain barriers. Exosomes, which are a very hot topic these days, that are released from every cell, tiny vesicles, they can pass through blood-brain barrier, and they have been shown in many studies that they can also be used to detect several cancer types. So in the future, I don't know when, but in the future, that they may be used for detecting brain cancers too.
Thank you.
So I just want to thank Dr. Reynolds again for giving us that thought-provoking, idea about using risk assessment and how we can break it down within the fire service. Thank you.